Bismillahirrahmanirrahim. Hadith of the day. Prophet Muhammad, peace be upon him, said, "Do not do evil to those who have done evil to you, but you deal with them with forgiveness and kindness." Assalamu alaikum, everyone. My name is Dr. Marina Akhtar, PGR Community Medicine. Today, my topic of presentation is malnutrition. I am presenting this topic under the kind supervision of Professor Dr. Saira Afzal. Learning outlines. Malnutrition, its definition and forms, concept of food gap, web of causation of malnutrition, level of prevention, and modes of intervention, and growth monitoring and nutritional surveillance, and recent updates and MCQs in the end. At learning outcomes. At the end of this presentation, the participants will be able to describe malnutrition, its form, the concept of food gap, the management protocol of an individual with malnutrition, and recommended strategies for its prevention, and differences between growth monitoring, nutritional surveillance, and the global recent advances in the context of malnutrition. Malnutrition. A pathological state resulting from a relative or absolute deficiency or excess of one or more essential nutrients. It comprises of four forms: undernutrition, overnutrition, imbalance, and specific deficiency. Undernutrition, a condition which results when insufficient food is eaten over an extended period of time. In extreme cases, it is called starvation. It is only an important cause of childhood morbidity and mortality, but also lead to permanent impairment of physical and possibly of mental growth of those survivors. Undernutrition. The term encompasses three frequently encountered problems: wasting or acute malnutrition, stunting growth, chronic malnutrition, and underweight. Overnutrition, a pathological state resulting from the consumption of excessive quantity of food over an extended period of time. The high incidence of obesity, erythema, and diabetes is attributed to overnutrition. Overnutrition, most prevalent form of malnutrition in developed countries, that lead to obesity, BMI greater than 40, grade 3 obesity, morbid obesity, and BMI greater than 50 called super obesity. Women have higher rate of obesity. Women's BMI increased by 1 kg per pregnancy. Relationship between alcohol consumption and adiposity and positive for men and negative for women. Cut off for obesity are in epidemiological studies, two standard deviation from median weight for height, and in layman term, the body weight in excess of 10% of expected weight. Overnutrition that cause obesity. Marked increase in obesity, particularly in urban areas of the poor countries and the USA among the poor population. Childhood obesity leads to adult obesity. Type 2 diabetes. Complication includes cardiac morbidity, retinal with blindness, and gangrene that leads to amputation, elevated cholesterol and triglyceride, and risk factors for cardiovascular disease. Complication of overnutrition include that cause systematic inflammation, that further leads to complication that include diabetes, psoriasis, psoriatic arthritis, and cardiovascular diseases. An imbalance, a pathological state resulting from a disproportion among the essential nutrients with or without the absolute deficiency of any nutrient. Specific deficiency, a pathological state resulting from a relative or absolute lack of an individual nutrient. These are the example of specific deficiencies. Under nutrition of minerals, that includes calcium deficiency that cause rickets, iodine deficiency cause goiter, iron deficiency cause anemia, and zinc deficiency cause growth retardation. And under nutrition of vitamins, that cause thiamine deficiency cause beriberi disease, niacin deficiency cause pellagra, vitamin C deficiency cause scurvy, and vitamin D deficiency cause rickets. Burden of disease in Pakistan. The double burden of malnutrition is becoming increasingly apparent in the country. Almost one of the three children are underweight, 28.9%, along a high prevalence of overweight, 9.5% in the same age group. Dimension of the problem. On a global scale, the five principal nutritional deficiency diseases that are being accorded the highest priority action are kwashiorkor, marasmus, xerophthalmia, nutritional anemia, and endemic goiter. Principal nutritional deficiencies, macronutrients, malnutrition, protein, calories, malnutrition, PCM, that includes kwashiorkor and marasmus. Micronutrients, malnutrition, that includes vitamin A deficiency, iron deficiency, anemia, iodine deficiency disorder. These five disease states represent tip of the iceberg, and much larger population is affected by hidden burden. Etiology of malnutrition, uh, primary malnutrition and secondary malnutrition. Primary malnutrition uh, are due to can be due to ignorant and erroneous food habits, low income, low purchasing power, scarcity of the food supply, and overpopulation. Secondary malnutrition can be due to infection, particularly respiratory, dial and intestinal malabsorption, congenital defects, metabolic disorder, insulin resistant, and diabetes. Concept of food gap. Protein energy malnutrition is primarily due to inadequate intake of the food gap both in the quantity and quality. Infection, most notably respiratory infection, diarrhea, measles, intestinal worms, which increase the requirement for calories, proteins, and other nutrients while decreasing their absorption and utilization. It is vicious cycle, infection contributing to malnutrition and malnutrition contributing to infection, both acting synergistically. This picture showing the malnutrition and infection cycle. Then start from inadequate dietary intake that lead to weight loss, growth, faltering immunity lowered, and mucosal damage that lead to disease, increase in incidence, duration, and severity that lead to appetite loss and nutrient loss, malabsorption, altered metabolism that leads to inadequate dietary intake. Web of causation. There are numerous contributory factors in the web of causation of the malnutrition. Poor environmental condition, large family size, poor maternal health, failure of lactation, premature termination of breastfeeding, adverse cultural practices relating to child rearing and weaning. Web of causation. Malnutrition is self-perpetuating. Our children's nutritional status at any point of the time depend upon his or her past nutritional history, which may be particularly account for the present status. To some extent, this nutrition history is linked to the mother's health and nutritional status, which in turn has been influenced by her living condition and nutritional history during her own childhood. This picture showing the influence of each generation's nutritional status on the following generation, starting from the nutritional status of the woman in of childbearing age, that influence the nutritional status of the pregnant woman, that influence the nutritional status of the lactating woman, and that ultimately affect the neonates and infant nutritional status, and that if influence the girl's nutritional status and nutritional status at puberty. Measurement of the undernutrition. In children, undernutrition is synonymous with growth failure. To get a measurement of the malnutrition in a population, young children are compared with a reference population known to have grown well. Use of the measurement of dimensions of human body such as weight, height is called anthropometry. Measurement of the undernutrition. Three common used anthropometric indices are weight for age, length or height for age, and weight for length. Measurement of the undernutrition, that anthropometric indices correspond to three states of malnutrition: weight for length or height for wasting, length or height for age, HFA for stunting, weight for age, WFA for underweights. Each of these nutrition indicators is expressed by standard deviation unit Z score from the median of the reference population, based on which undernutrition may be classified as a mild, moderate, and severe. This picture showing the different classifications, their definition, their grades. For example, Gomes classification, that grading is mild, moderate, and severe. 75 to 90% weight for age, and this is mild, and 60 to 74% in moderate, and less than 60% and severe, and also in other classifications. Underweight. A child whose weight for AWFAZ score is at least 2 standard deviation below the median in the World Health Organization Children Growth Standards. Underweight, it is a composite measure of stunting and wasting and is recommended as an indicator to assess the change in the magnitude of the malnutrition over time. It can result from either chronic or acute malnutrition or both. It is often used as a basic indicator of the status of a population's health. Evidence suggests that mortality risk of of children who are even mildly underweight is increased. Stunting. A child whose height for age HFAZ score is at least 2 standard deviation below the median of the World Health Organization Child Growth Standard. Wasting. A child whose weight for height Z score is at least 2 standard deviation below the median in the World Health Organization Child Growth Standards. Wasting represents a recent failure to receive adequate nutrition and may be affected by the recent episode of the diarrhea. It indicates current malnutrition resulting from the failure to gain weight or actual weight loss. And the wasting in individual children and populations can change rapidly and shows marked seasonal patterns associated with changes in food availability or disease prevalence to which it is sensitive. Severe acute malnutrition. A child whose weight for height Z score is 3 standard deviation below the median in the World Health Organization Child Growth Standard. Mid upper arm circumference less than 115 millimeter or has presence of nutritional edema. Severe acute malnutrition, Sam. It can be an indirect cause of the child death by increasing the case fatality rate in the children suffering from the common illness such as diarrhea and pneumonia. Children who are severely wasted are 9 times more likely to die than the well-nourished child. Kwashiorkor is also called edematous malnutrition, a form of protein energy malnutrition when the main cause is inadequate protein intake and low concentration of essential amino acid. It is severe form of the undernutrition which develops in individual on diet with a low protein energy ratio. The main symptoms include edema, wasting, liver enlargement, hypoalbuminemia, steatosis, and deep pigmentation of the skin and hair. Marasmus, a form of protein energy malnutrition when the main cause of inadequate intake of both protein and energy. It is the form of severe cachexia with weight loss as a result of wasting in infancy and childhood. Main symptoms are severe wasting with little or no edema, minimal subcutaneous fat with severe muscle wasting, and non-normal serum albumin levels. This picture showing the differences between Kwashiorkor and marasmus, which we have discussed already. Preventive measures includes health promotions, measures directed to the pregnant and lactating women, education, distribution of food supplement, promotion of breastfeeding, development of the low-cost weaning foods. The child should be made to eat more food at frequent intervals, and measures to improve family diet. Preventive measures include health promotion, nutritional education that include promotion of the correct feeding practice, and home economics, family planning, and spacing of the birth, and the health family involvement. And other preventive measures include specific protection. The child's diet must contain protein and energy-rich food. Milk, eggs, and fresh fruits should be given if possible. Immunization of the children as per EPI. Growth monitoring on the growth chart, especially of the all children under 3 years of age, and food fortification. Other preventive measures include early diagnosis and treatment, periodic surveillance, early diagnosis of any lag in growth, early diagnosis and treatment of infections and diarrhea, development of the programs for early rehydration of children and diarrhea, and development of supplementary feeding programs during epidemics, and deworming of heavy infested children. Other preventive measures include rehabilitation, nutritional rehabilitation services via outpatient therapeutic feeding, ready-to-use supplementary food (RUSF) and ready-to-use therapeutic food (RUTF), hospital treatment if medical complications arise, and follow-up care. Management of SAM, severe acute malnutrition. The body of malnourished child may have compensated for micronutrient deficiency with lower metabolic and growth rates. Spontaneous refeeding may mask these deficiencies. Nutritional rehabilitation should be initiated and advanced slowly to minimize these complications. Follow WHO guidelines for this malnutrition. Treat and prevent hypoglycemia, treat and prevent hypothermia, treat prevent dehydration, correct electrolyte imbalance, treat and prevent infection, correct micronutrient deficiency, initiate refeeding, facilitate catch-up growth, provide sensory stimulation and emotional support, prepare for follow-up after recovery. And these all 10 steps are divided in two phases: stabilization and rehabilitation. Stabilization takes place from day 1 to day 7, and rehabilitation takes 2 to 6 weeks. Management of SAM. When there are no medical complications, a severely malnourished child who has an appetite is given a standard dose of Rutef adjusted to weight and guided by appetite. The child consume a food at home directly from the package with supervision from caregiver at any time of the day. A child being treating for severe acute malnutrition generally requires a total of the 10 to 15 kg of Rutef consumed over the period of 6 to 8 weeks. Refeeding syndrome. If aggressive carbohydrates are given during the course of the refeeding, there is an increased insulin level resulting in shifting of potassium, phosphate, and magnesium into the cell. The severe hypophosphatemia during refeeding produce weakness, rhabdomyolysis, neutrophil dysfunction, cardiorespiratory failure, seizures, altered level of consciousness, even sudden it can sudden death. Assessment of nutritional status. A nutritional status of individual is often influenced by the adequacy of the food intake, both in terms of quality and quantity, and also by physical health of an individual. The nutritional status of the community is the sum of nutritional status of the individual who form that community. The purpose of nutritional assessment is to develop a healthcare program that meet the need defined by that assessment, including evaluation of the effectiveness of such programs. A proper nutritional evaluation demands a multi-angled approach covering all the different stages in the natural history of nutritional disease. This picture showing the natural history of nutritional disease, method of nutritional assessment and their relationship to the natural history of disease. Pre-pathogenic period, that we take from a food balance sheet. We take data from the food balance sheet and dietary surveys. And in the period of pathogenesis, we take data from the mortality data, clinical science and morbidity, anthropometric studies, and biochemical studies. Nutritional surveillance. Keeping watching over nutrition in order to make decision that will lead to the improvement in the nutrition in the population. Three distinct objective: aid long-term planning in the health and development, provide input for program management and evaluation, and give timely warning and intervention to prevent short-term food consumption crisis. And this picture showing the growth monitoring and nutritional surveillance steps. And this picture showing the indicators for the nutritional surveillance, maternal nutrition and infant and preschool child nutrition and school children nutrition and their indicators. The assessment methods include the following: clinical examination, anthropometry, biochemical evaluation, functional assessment, assessment of dietary intake, vital and the health statistic, and ecological studies. Now coming to our recent update session. UNICEF for every child, Pakistan. Key factors include nearly 10 million of the Pakistani children suffer from stunting. 8 out of 10 children in Pakistan don't eat right type and quantity of the food, and pregnant women need a diverse diet rich in vitamins and minerals. Though this is really the case in Pakistan, only 38% of the children are exclusively breastfed for first 6 months of the life. As per result, more than half of the children under 5 years of the age are deficient in vitamin A, and 40% are deficient in both zinc and vitamin D, and nearly 62% are anemic. Now, solution to that problems. In order to prevent and reverse the stunting, UNICEF Pakistan is focused to support the 1,000-day nutrition window during the child's nutritional deprivations can be reversed. And the breastfeeding, they encourage breastfeeding. Breastfeeding is a critical nutrition intervention for improving both the dietary quality and the quantity of the children. Breast milk alone meet all the nutritional need of infant up to 6 months of the age. In addition, providing immunological and psychological benefit of mother's diet affect the health and the well-being of the both mother and the child. UNICEF is supporting scaling up of the nutritional specific intervention that focus on the micronutrients, supplementation, fortification, and diversified diet for pregnant women and children under 2 years, along the enhanced breastfeeding practices. According to WHO, World Health Organization, Nutrition and Food Safety of Pakistan, and they also uh, pro, they also given their planning and strategies to improve malnutrition. These key points includes advocacy around baby-friendly hospitals initiative and scaling up nutritional stabilization centers, supporting and training technical guidance on adolescent nutrition and supplementation, advocacy around the importance of adolescent nutrition, advocacy on implementation of food safety regulation and training to food inspector, and strengthening food functionality of health and nutritional surveillance sites, and national and provincial advocacy. WHO decade of action theme on nutrition, and technical assistance for national quality control standard for food fortification. There is an article, malnutrition and its influence on sepsis outcome in elderly patient. And this article conclude that malnutrition significantly worsen the outcome for elderly sepsis patients, increasing ICU admissions, ventilation needs, mortality rates, readmission, emphasizing the need for proactive nutritional and interventions. Now coming to our MCQ session. Our first MCQ is: a researcher want to assess the nutritional status of a representative sample of the children in village A, whether it is good or bad, is better or worse than that of the village B and C, and whether it is improving or deteriorating over time. The most appropriate means to carry out such a assessment in the community is: option A, anthropometry; option B, clinical examination; option C, functional statistics; option D, growth monitoring; option E, nutritional surveillance.
Option A.
Answer is option E, nutritional surveillance. MCQ number 2 is: a 3-year-old child in a rural community has a height for 8Z score of 2.8. The child's weight for height is normal and there is no sign of acute malnutrition, what is the most likely diagnosis? Option A, wasting. Option B, stunting. Option C, underweight. Option D, marasmus. Option E, obesity.
B.
Yes, B is the right answer. MCQ number 3 is a 45-year-old man present with numbness and tingling in his hands and feet, difficulty walking, and swollen, beefy, red tongue. His diet primarily consists of polished rice and a little else. What is the most likely nutrient deficiency causing this symptom? Option A, vitamin B12 deficiency. Option B, thiamine deficiency. Option C, niacin deficiency. Option D, folate deficiency. Option E, vitamin E deficiency. Answer is option B, thiamine deficiency. A 2-year-old child with severe acute malnutrition, Sam, is assessed at the community health center. His weight for height Z score is 3.2. 3.2 and his mid upper circumference is 10.8. The child is alert, has no edema, and is able to eat. What is the most appropriate next step? Option A is admit in hospital for nasogastric feeding. Option B, provide ready to use therapeutic food and manage as an outpatient. Option C, start immediate high protein feeding. Option D is give only oral hydration therapy. Option E is referred to intravenous fluid therapy.
Option B.
Yes, B is the right answer. Rutif. MCQ number 5 is a 5-year-old girl is brought to clinic with the complaint of the irritability, swollen legs, and the swollen belly. Her diet mainly consists of the maize. On examination, she has sign of edema, hepatomegaly, and flaky paint dermatitis. What is the most likely diagnosis? Option A is marasmus. Option B, rickets. Option A, plagra. Option D, kwashiorkor, and option E, beriberi.
C option.
It is D, kwashiorkor. MCQ number 6 is a young anxious mother visit the primary health care facility and expresses concern about the lack of the age appropriate growth of her infant who is currently 6 months of age, and the most appropriate mean to detect early onset growth faltering in his child would be option A, anthropometry. Option B, clinical examination. Option C, functional statistic. Option D, growth monitoring. Option E, nutritional surveillance.
A.
MCQ answer is D, growth monitoring. A community health worker is screening children for malnutrition using MUSC tape. A 15-month-old child has a MUSC of 11.0 centimeter. What is the most appropriate classification of the child's nutritional status? Option A, normal nutrition. Option B, mild acute malnutrition. Option C, severe acute malnutrition. And option D, overweight, and option E is stunted but well nourished.
It's B.
This
C.
is C, severe acute malnutrition. MCQ number 8 is a severely malnourished child with marasmus is admitted to the hospital. Which of the following laboratory finding is most commonly associated with this condition? Option A, hypoalbuminemia and edema. Option B, severe anemia with megaloblastic changes. Option C, normal serum albumin with low glucose and electrolyte imbalance. And option D, hypercholesterolemia. Option E is high serum potassium and sodium. Answer is option C, normal serum albumin with low glucose and electrolyte imbalance. A 14-month-old child is in the clinic with the severe weight loss, visible ribs, loss of subcutaneous fat, muscle wasting. Child appears alert but irritable. His weight for height Z score is 4 standard deviation. What is the most likely diagnosis? Option A, kwashiorkor. Option B, marasmus. Option C, rickets. Option D, vitamin A deficiency. Option E, moderate acute malnutrition. Answer is option B, marasmus. MCQ number 10 is a 30-year-old man present with night blindness and frequent infection. And on physical examination, he has dry, scaly skin, without spots on conjunctiva. And what nutritional deficiency is most likely responsible for his symptoms? Option A, vitamin A deficiency. Option B, vitamin D deficiency. Option C, vitamin C deficiency. Option D, zinc deficiency. And option E is iron deficiency.
A.
Yes, A is the right answer, vitamin A deficiency. This is the key to MCQs, and these are references of my presentation. And this is the YouTube link where our presentations are uploaded. Kindly like and subscribe this channel. And thank you.
Thank you, Dr. Marina.